Welcome back to another amazing episode of Medshield Movement Connect show with me, Dr. Fez. And it is the most wonderful time of the year. It's Women's Month. And to celebrate all of those amazing women in our lives, we're going to be talking about women's health with a gynecologist, Dr. Marise Subryan. Get ready to know what you don't know about being body brilliant. This is the Medshield Movement Connect show, where we connect the dots between fitness, health, wellness, nutrition, and of course you. Hosted by me, Dr. Fez Mkhize, and a special guest that we have every month, sharing knowledge, insights, and groundbreaking tips on how to get fitter, be stronger, and live healthier. Turn up the volume and listen close. Today you amplify. It's the Medshield Movement Connect show. Let's go. Marise, thank you so much for sitting down with us.
Thanks so much for having me.
Now, it is women's health that we're talking about, and it is a topic that I always like illuminating. Could you please take us through the 4 phases when it comes to the menstrual cycle, as well as the ovarian cycle, the difference between the menstrual cycle and the ovarian cycle?
Sure. So, to simplify everything, there are 4 phases in a menstrual cycle, but the other names for it can be an ovarian cycle or a uterine cycle. It's all exactly the same thing. This would start off with a period or a menstruation, that's your bleeding phase, anywhere between 3 to 7 days. In the background of that is the follicular phase. That's where your brain is instructing the ovary to start to bring up new immature cells so that we can hopefully get a nice mature egg to ovulate at around about 2 weeks later. In that time, we're also building up the period lining. Phase 3 is ovulation. To get to that stage, things have to already be working well in motion so that that egg is mature enough and strong enough that we even think it could turn into a healthy baby eventually. Once you release your egg, that's ovulation, generally 2 weeks before you have your next period. The phase after ovulation is your luteal phase. That's the time where your body is trying to hopefully believe that you're pregnant. And once it decides that actually you're not pregnant, all the hormone levels drop down and your body will once again bleed or shed out the period lining and start the entire phase again.
So clearly it's this beautiful kind of orchestra of when one thing does this, another one goes down, inhibitory, one will then do something for a certain period of time. And I love the fact that with these kind of cycles, because you can sometimes get lost in the details, you've explained it so beautifully in terms of your body has an egg, it's trying to make sure that it gets fertilized and gives it an environment that allows somebody to be pregnant. If you had to explain in terms of those phases, how somebody would feel as these phases are going, because you're saying hormones, and hormones generally have a whole kind of sequelae of things that they do in the body.
Sure. So during the time of your period, that's when most ladies might feel cramping pains. They might even have headaches, bloating, constipation, or even diarrhea. Others might have a lot of mood disorders. Generally the time to be nice to yourself and kind. As the period is ending and you start to get into your follicular phase,
and just when you say period, is that when you actually are seeing it?
When you are seeing the flow of blood out of your body, and that's anywhere between 3 to 7 days. But in the background, from the very first day of your period, the follicular phase is a high estrogen time, and with estrogen, you're going to feel wonderful. Your skin's great, your hair's great, your libido may be up, you're stronger at gym, you put on more muscle, you are healthier with your metabolism and your food intake, you don't have as many cravings, and that's just estrogen. Once you get onto ovulation, that's where you have the highest peak in sex drive. That's designed because your body is wanting you to become pregnant at the time when you are most likely to be fertile. The luteal phase, that's a time of high progesterone. Progesterone is something that can make you feel a little more sluggish. It can make you feel that you're having different cravings. Your skin may be breaking out, you may be having constipation, you may even start to have a little bit of cramping going on. And that's when we start to have drops as the final phase of the luteal phase, all the way down to having an actual period again.
Well, look at that. I mean, I love that it's explained in that way, because I think a lot of people kind of just go, okay, menstrual, they just think of the time where you're actually shedding, or people talk about the PMS and people
Yes.
being angry and then feeling irritable and all of these things that come with it, which sometimes I feel also stereotyped, because as guys, you're like, yeah, she seems different
Yes.
during that period of time. But it really is something that continuously happens up until you're kind of menopausal, and that is your life cycle in terms of your count for eggs, which I wanted to ask you, when it comes to you having eggs that are released and potentially being able to be pregnant, normally you have a set number of eggs?
You are born with all the eggs that you will ever have. By the time you are born as a newborn little baby girl, you probably have about 500,000 eggs.
Wow.
And that's all that you've got for your entire life. Although only one egg is usually ovulated per month, you're losing somewhere in the range of 20,000 to 50,000 per month.
Wow.
And that isn't accounting for different things like infections, surgeries, or maybe other conditions that may affect your ovary, like autoimmune conditions or cancers. Those can drastically deplete the number of eggs.
Wow. I mean, thinking about it then, if you're somebody who wants to fall pregnant, you are very aware of this kind of cycle, the cyclical kind of effect that happens in your body. When you're trying not to fall pregnant, though, I think you also then become aware, and I think a lot of people at home know the barrier methods in terms of condoms
Yes.
and preventing in that way. Could you maybe explain to me where contraceptives work? Because we talked about estrogen peaking, and then you ovulate 14, and then all of a sudden progesterone is taking over, and that has its own effect when it comes to your uterus. Could you tell me how the contraceptives work and what they actually target?
Absolutely. So we've got different types of contraceptives. They are hormonal and non-hormonal. And even within the hormonal, some of them act in different ways to others. So let's start with non-hormonal. Things like condoms or barrier contraceptive, and that includes things like diaphragms.
Yeah.
They have nothing to do with your cycle. We are simply trying to put a boom gate at the time of sexual intercourse.
I love you call it a boom
It
gate.
is a boom gate.
It's like, bounced.
Right?
I know.
And other things like spermicides may be used at that time as well. Another option that's non-hormonal is a copper intrauterine device, previously known as a loop. Now, this is quite an outdated type of contraception, but it is still widely available because it is very cost-effective.
Yeah.
That does not have any hormones in it. It's placed within the womb, and it is only the copper that creates an environment where a sperm cell or an egg or an embryo would not want to live.
Yeah.
And so that doesn't affect the cycle, but it is something that could give you heavier or more painful periods.
Okay.
Then we go into hormonal. Some of the hormonal options, like the pills, patches, vaginal rings, implants, they are designed to keep a steady state of hormones throughout the entire month and prevent you reaching ovulation. If you don't have the fluctuations, your body doesn't know what it should be doing, and it remains at the level of the instruction from whatever hormone we are giving.
Okay.
If you're not ovulating, then your body will not go through the different phases. Even within these medications, we've designed different types. Some that stay exactly the same for 3 weeks, and you bleed during a placebo week, or others that try to more closely mimic a cycle and give higher estrogen in week 1, an equal level in week 2, and a higher progesterone in week 3.
And I'm assuming, of course, as you're explaining it, this at least allows you to predict what's happening within your body, as opposed to perhaps you're just going, I think I might be in this phase, I might be fertile, be able to kind of release an egg. So when it comes to people and what contraceptive choice they want to use, what do you usually tell people? Like, how are you catering that family planning to them?
You've got to take a patient as an individual.
Sure.
Each woman will have different contraceptive needs at different times in her life. She might have different medical disorders at different times in her life. She might get new information about her family history that can influence what we choose. Yeah. So the first choice that you decide to use when you maybe start to have sex and want to use contraception may be very different than what you might want to use when you're perimenopausal. Sure. But there are options that are available that don't affect your menstrual cycle at all. So those would be options like the newer types of intrauterine device, a Kyleena or Mirena. And I'm not sponsored by anybody, but I do believe that that is one of the greatest innovations in contraception that we've had in a long time. It allows you to still have your menstrual cycle in the way that your body would like it to do. The brain is still instructing the ovary is still instructing the uterus to grow a period lining. But just right there at the end, the Mirena or Kyleena will ask the period lining not to grow. So it is the least effect on your period lining because its design is not to prevent ovulation, but to work with you and only have a contraceptive effect right down at the uterus level.
And I love those kind of innovations because these are the kind of things you want to make sure that you're doing with time, with the knowledge that you have, and of course with the technology we have. And speaking about technology, we live in a social media space and people are having conversations, which is great, but there are also myths that are dispelled. And I'm sure you have patients who come in and they ask you all sorts of questions around some of the most absurd things. I mean, the hot topics that we're talking about, tampons and lead being in tampons and whether that's good or bad. What are some of those myths that you've come across that, of course, we can have everybody sitting at home now having those dispelled by somebody who has the knowledge?
Great. So the one that really gets discussed quite a lot in my rooms are young ladies who have been incorrectly told by either their family members or elders that they are not allowed to use tampons, menstrual cups, or menstrual discs because in some way that affects their virginity. Virginity is the first time that you have sexual intercourse. That has absolutely nothing to do with what type of menstrual product you use. Another thing is that people having periods don't necessarily need to fit the mainstream. You may be somebody who is transgender. You may be somebody who doesn't feel comfortable with having products inserted into your body. So we have a range of different menstrual products that even fit within underwear types like boxers or briefs. We have different options for people that don't want to insert something into their body, even things like period underwear or period swimwear. So you don't even need to feel that you are using outdated products or products that might feel feminine, and you may be somebody who doesn't align with that kind of things.
I mean, I love that you're considering these things. It also speaks to you being a young gynecologist. It's something that you're trying to bridge the gap between the old way of doing things and also what people are wanting and the need that they have in this day and age right now. And I mean, speaking of that, I have friends, and I've also had patients come in, and it's become quite a big talking point, endometriosis. Could you explain it for everybody at home what that is, and also how bad it could get, and how many people you're seeing in this day and age actually coming in with this issue? Because I've seen and come across it quite a bit in social media.
Endometriosis is one of the most difficult gynecology disorders that are still existing. The truth is we don't know enough about endometriosis to know how to solve it. We do have some options available, but on average, a lady will wait approximately 10 years before she's diagnosed with endometriosis. And that's because the types of symptoms are so non-specific. I've even had patients that presented with endometriosis with nosebleeds.
Wow.
Every month, instead of only bleeding from her uterus, she also had endometriosis in her nasal cavity. And that was something where an ENT doctor, luckily enough, picked it up and sent her across to the endometriosis specialist.
Really, I've never heard that. That must have been insane.
It can go anywhere it wants to.
Yeah.
It acts in a similar way to a cancer, although it's not officially a cancer. It can grow in any type of the body. It is quite aggressive in its spread. And we sometimes have to cut it out or resect, and in other times we use medication to try to squash it down and prevent new growth.
Of course.
The greatest difficulty with endometriosis is ladies who have endometriosis often have other family members who also had it. And because those family their daughters or sisters or friends to be seen by a gynecologist and managed, they often say things like, well, yours is not as bad as mine. Or mine was worse than yours. Why do you need help when I didn't need help?
Yeah.
Okay.
Yeah.
endometriosis isn't just an issue of painful periods or difficulty with falling pregnant. The long-term effects also include higher rates of ovarian cancer, chronic pelvic pain, and more difficulty with menopause. So it is something lifelong. As soon as you may be diagnosed with endometriosis, we want to be able to give you that long-term care. So it isn't just an early stage of life that's being managed, but we help to give you ideas about what could be a good fit for you all the way up to the day you die.
Absolutely amazing. And I think that's the important part, is that you see it as something that involves you in your entire life, and you're trying to figure out, as you said earlier, patients are specific, and you want to try find the specific management that's going to help the people that you come across. And speaking about people you come across, could you please, and make it as streamlined as you can for everybody at home, so they don't have too many dots to connect. Could you tell us just a couple of key points when it comes to the menstrual cycle and women's health, and how somebody can really be optimized, and how they can also have a great interaction with their healthcare provider?
Sure. I think the most important thing is to focus on your own body's health. If you are not taking care of your body as a whole in terms of your mental health, physical health, prioritizing lean muscle mass above the percentage of adipose tissue, if we're not managing glycemic index, if we're not managing the way that your muscles, joints, your skin, your hair are all interacting together, we're actually not going to be able to address menstrual health in the way that it should be. Everything interacts with each other. Something as simple as a thyroid disorder can affect your periods. Diabetes or high blood pressure can affect your periods. Medication that you're on can affect your periods. And something that has been more well known now that Ozempic has become very fashionable, Ozempic does also prevent the full absorption of your oral contraceptive pills, which means that either you have a higher risk of becoming pregnant, or you could have more irregular or heavy periods if you're using Ozempic and an oral contraceptive at the same time.
Oh, look at that. The more you know, right? But before we go, I know I was kind of making sure that you had something streamlined. I always have some sort of kind of bullet points for everybody at home, because I like to have my own little speed round. We spoke about contraceptives. I want to know from you, if you had to give me, I'm not even going to go 3 today, I'm going to go 4.
Sure.
Give me your 4 that you generally recommend, because you think they cover a lot of the bases and people receive them quite well, and they fit quite well into a lifestyle. What would those 4 types of contraceptives be? Go.
My number 1 is a Mirena.
Boom.
And that is because it has dropped hysterectomy rates by 85%.
Wow.
It is something that in the majority of ladies that use it, they will, by choice, have no period during the 5 years that it is inside your body.
Wow.
Okay? It's something that will reduce pain, reduce cysts, reduce heavy periods. It's suitable to be used in ladies that are obese, have cancer, and have other medical disorders. It doesn't interact with other medication. So that is my absolute number 1.
Feels like that's number 1 with like a gap.
There's
like
a
number
massive
3.
gap below that. Okay. Other options that I do like are oral contraceptive tablets. The reason for that is, if you're not trying to use it as a contraceptive, it's something that more easily and more cost effectively can be started and stopped. There are hundreds of different formulations, and newer formulations have much lower risks of blood clots or DVTs. They help you with migraines, they reduce cancer risks. They really are great for helping ladies who are younger and older. Another option is something like a vaginal ring, which is not often discussed.
No.
This is exactly the same hormones as an oral contraceptive tablet. But it's something that you can insert into the vagina. It remains in for 1 week. Each week you would remove one ring and place in a new one, and in week 4 you would bleed, because that is the same as your placebo week and there's no ring. This is good for ladies that are a little more forgetful. They can't remember to take a tablet every day, or they have medications or medical conditions that are affecting absorption of a tablet. The vaginal ring bypasses all of that and allows adequate absorption. Another option is a full sterilization. Sterilization is removing or tying your tubes. This is a surgical procedure. It's permanent, but in ladies that might want to get pregnant after this, there is still the option of IVF. It allows you to never have to worry about pregnancies after that surgical procedure. And it can often be done at the same time as another surgical procedure that you're already going in for. If you have had issues with hormonal medication, or you just choose that you don't want to use hormonal medication, a sterilization is allowed to be performed at any age, whether or not you have previous children, whether or not you want to have children. It's your right to make that decision.
I love it. I mean, sterilization, you tied that up so well.
Absolutely.
Tied that up so well. I feel like this
I got it there.
I got that doctor flow. There you have it, another incredible and highly informative episode of Medshield Movement Connect show. And listen, if you are thinking you need more information, you need to figure out more things when it comes to your own health, make sure that you go across and you can go to your social media, of course.
Sure. My social media is Subryan Obs and Gynae. We're on TikTok, Facebook, Instagram, LinkedIn, all the things.
Or find somebody that's close to you if you need to have that face-to-face interaction. The more you know, the better your health will be. And that's me, Dr. Fez, signing out.